Dr. Bhanu Priya, who the title of her talk is I Am Confused.
A very good morning to all of you. So today I'm going to discuss about a patient whose clinical course really confused me. So this is the story of this gentleman, 57-year-old male, who presented to us on 2018, came for regular checkup. He was hypertensive and diabetic. On clinical examination, the best corrected visual acuity was 6/6 in both the eyes, with myopic correction of 2.5 in the right eye and 2.75 in the left eye, and the rest anterior segment was within normal limit. On posterior segment evaluation, the central fundus was within normal limit, but on the peripheral examination, in the left eye, there was a temporal retinal break was there with the surrounding pigmentation. So as the patient was asymptomatic and there was no risk factors associated, like there was no association of any trauma, there was patient was not undergoing any ocular surgeries, so we decided to follow up this patient in 6 months. But patient came after 6 years with the sudden vision loss in the left eye, and the visual acuity was finger count at 3 meters. On examination, left eye retinal detachment was noted. So 6 years earlier, when we saw this patient, there was a temporal retinal break, and now the patient came with this retinal detachment. There was no other peripheral retinal degeneration was there. So apparently the same break which was noted 6 years earlier is the primary break. So I am confused here, like, have I done any mistake? Should I have lasered 6 years ago this lesion? My single 5-minute procedure could have prevented this mishap. But what does the protocol says? As per American Academy of Ophthalmology, the asymptomatic tears, asymptomatic retinal round holes, treatment is rarely recommended. Patient should be kept under observation. So I think as per protocol, I have not done any grave mistake here. So what are the conditions when we need to laser these degenerations? As per IGO, when the patient was asymptomatic, if the patient is single-eyed, if the fellow eye is affected by an RD, if patient is undergoing any cataract surgery, refractive surgery, laser capsulotomy or intravitreal injection, and if there is a family history of RD and there is inability to assess any ophthalmological care, then we need to laser these lesions. I would like to highlight that the prevalence of asymptomatic retinal break is approximately 6%, and the cumulative incidence of retinal detachment by an asymptomatic retinal break is ranging from 0 to 13.8%. So if we think of lasering all the asymptomatic breaks, we know the world population is 8 billion, 6% will be 480 million, and we will end up lasering 480 million people, which is practically not feasible. So I think I did right here, but how can we avoid this regrettable incident? I think that proper counseling is the key. We need to explain the patient about the symptoms, not only when they will come to you when vision will, we have lost the vision. So we need to explain the patient about the floaters, flashes, along with that if they are seeing any dark spots, any sluggish lines, and if there is loss of peripheral vision also. So we need to explain very carefully to the patient and we need to follow up this patient. Thank you so much for your patient listening.
So any history of trauma in this patient?
No, ma'am.
No.
ma'am.
So traumatic breaks also, they don't follow any rule because the vitreous becomes degenerate very quickly,
Yes.
and then
Yes. There was no risk factors.
no risk factor.
Thank you. We have
Thank
5
you.
minutes if anybody has any comments or any question. Yes, Dr. Rajkumar.
Regarding this case, I like to err on the side of prophylaxis.
Okay.
One thing. Second thing is, I don't know, you must have seen the patient carefully with the dynamic indentation, palpation of the retina. If you see some pigmentation, but maybe the hole was not, the pigmentation was not all around. So that is why maybe some fluid has gone into this. If you are talking of the world incidence in 480 million, no, you are not going door to door and doing a screening survey and then
Yes,
saying
sir.
that we have to treat 480 million. These are some of the patients who are coming to you. If they come to you, if you see a break which you think should be treated, it should be treated. Thank you.
I think other criteria like if it is high myo, if the other eye has, if there is a family history, anything which might predispose should be kept in mind. And I think, as Dr. Rajkumar said, indentation is very important in these cases. If a
Yes, sir.
peripheral, you see a peripheral hole, not a tear but a hole with pigmentation, you indent it.
Yes.
And if you indent it, you will see the pigmentation is not all around, especially at the towards equator. So indentation is very important, and other predisposing factors should be kept in mind.
Yes.
But it is your patient, you have to treat, you have to warn. If I had a patient like that, I would tell him that the earliest possible symptom you must report.
Yes, sir.
But that is only if the pigmentation is fully around.
Noted, sir.
It's difficult situation. As you
Yes,
said,
sir.
everybody is confused.
Yes.
Thank you everybody for
Thank you.
your kind